I would probably say I'm upbeat, I'm positive, I'm outgoing. I tend to be a pleaser. I want everyone else happy before me, and I'm high energy. I don't sleep a lot. I don't like to sleep. I feel like I'm missing something.
Donna is this extremely vivacious, one of those people who, everybody's looking at because, why is she so, why is she so happy at this moment? Why is she so engaging? And she's just one of these people. And I'm sure she was like this before, but maybe this has even brought more of it out in her. So she's very interesting personality, not the typical I'm a cancer patient kind of personality.
Donna Kravitz of Englewood, New Jersey, has a blood cancer called multiple myeloma. It's a disease that she has come to grips with over the years and seems to manage in her own way, never letting it control her life.
Cancer doesn't define me. It can't. Multiple myeloma doesn't define me. I'm who I am. I happen to have multiple myeloma, just like I'm too short and wear too high heels, and my hair is too long and I'm too loud. But multiple myeloma can't define me. It's something that we live with. Everybody's got something. Everyone's got some sort of something going on in their life. I don't sit in that. You know I don't sit in that. That's the sick people. I sit here.
All right.
I was diagnosed April 14th, 2011.
Your hair is in the way.
And I had a 10-minute pity party and then said, what am I going to do? Move on. I found an amazing team of doctors and I put my faith in them. And I move on. There's nothing more that I could do.
Dr. David Siegel is Donna's oncologist at the John Theuer Cancer Center in Hackensack, New Jersey.
Donna is unique, and I think unique in a very positive way. Cancer patients deal with a lot. Then there are others who embrace the idea that they have the cancer and understand it, but recognize that this is just one of many things that goes on in life. And she is as good, probably the best example of that kind of attitude about their cancer. She's going to live her life.
How are you feeling, Donna?
I feel great. Don't ask me any questions. Don't ask me symptoms, side effects, because I'll start having them. Business as usual. I just handle it very differently. I don't want specifics. I walk into the hospital to get my shot. I say hi to everybody. I get my blood work. I go upstairs. I meet with the doctor. Done. Just like it's any other errand. And that's how I do it. I put my head down and I go.
Typical of this type of cancer, multiple myeloma can exhibit a stealth-like quality, often presenting little to no symptoms in the beginning. The diagnosis of cancer caught Donna completely by surprise.
I had the flu. Basic. I actually had your basic end of winter cold. Everyone in my office had it. I got it too. So I went for a blood test because they wanted to put me on an antibiotic. And it turned up no symptoms at all. They asked me, did anything bother me? Did anything hurt?
Well, in the old days, when we used to diagnose patients almost exclusively when they had symptoms, today a lot of patients get discovered because they have abnormal blood tests. So they get discovered before they actually come and start complaining of something.
Symptoms can run the gamut, from loss of appetite and fatigue to frequent infection and bone pain, which is often a common indicator.
So then I went to Dr. Siegel and had a bone marrow biopsy, which they also say is the most incredibly painful thing you could ever have. He's a master. I really felt nothing. A little pinch. It was not that bad. And he confirmed it with the bone marrow biopsy, and I started on my journey.
Myeloma goes into the category of blood cancer, so very different than breast cancer or colon cancer, where it starts in one spot and the cells start to grow when they're not supposed to, and then one day acquires the ability to spread. These are blood cancers, so these are cells that don't have boundaries. So myeloma is basically a kind of leukemia. It is a cancer of blood cells that mostly hangs out in your bone marrow, and that's really the definition of a leukemia. It doesn't get called leukemia because back in the early 1800s, when it was first described, people didn't really understand what it was, and it got this name, multiple myeloma. So what that actually means is multiple tumors growing out of the bone marrow, and that name has stuck.
One of the classic markers of multiple myeloma is the overproduction of one particular antibody that can appear in a blood test.
So that is the M protein that we're talking. It actually looks like an M as well, so some people say that it's called M protein because of that. But that's very important in myeloma because unlike lung cancer where you could put up a chest x-ray or a CAT scan and you could see that there's a tumor there that's not supposed to be there, in most patients with myeloma there's no picture because it's sort of spread out throughout the blood and in the bone marrow. So the way we tell what's going on with the disease is by measuring the amount of that M protein, that abnormal antibody that is being made by the cancer cells. So if it gets bigger, the disease is getting worse. If it gets smaller, the disease is getting better.
High numbers of the M protein can wreak havoc on the body. Patients can suffer from skeletal pain due to bone degeneration and kidney failure.
That protein, that antibody that the myeloma makes, can basically clog up the kidneys, so it's not uncommon for patients with myeloma to present with renal failure.
After an initial schedule of chemotherapy drugs, Donna was prepared for a stem cell transplant. That's because myeloma patients can no longer produce normal blood cells. In Donna's case, she went through 2 autologous transplants, a procedure where healthy stem cells are taken from one's own blood or marrow, frozen, and then sent through an IV back into the body.
We clean up their bone marrow so they have lots of healthy bone marrow.
The next step then involves the use of strong chemotherapy drugs to kill the bad cells.
And then we can take those cells that we've collected, those healthy bone marrow cells, and give it back to the patient. Some of these patients will then go for many, many years without the disease coming back, and a few, small number of patients will actually be cured of their myeloma.
I sat for 3 days, arms outstretched, and that was worse than the transplant. Arms outstretched for 7 hours at a clip while they they take the blood out, it spins, they pull out the stem cells, put your blood back in. And then the nurses all sing you happy birthday because at that point, you're all new. You actually have to get all your baby shots again when you're done with the process because they clean your blood to such an extent.
Hey Thomas,
Hi.
How are you?
All right.
In Durham, North Carolina, Thomas Good, another myeloma patient, wasn't as lucky with the results of his autologous cell transplant and had to look for other treatments. Dr. Christina Gasparetto, internist and hematology specialist at Duke University, has been Thomas's attending physician for over 10 years.
Thomas is very unique because he was diagnosed with myeloma at a very young age. So myeloma remains a disease of the older population, even if the average age at presentation is coming down, is going down, and we don't know why. I think 20 years ago, it was the average age at time of presentation was about 70, 73, and now is more kind of in the 60s. And we don't know why more younger patients are diagnosed with myeloma, but Thomas was diagnosed with myeloma very early, very young age, in the mid-30s.
Well, you know, with myeloma, everyone is different. My symptoms is pain. So every time that I have problems with myeloma, it always pain is my main symptom. So I'll have, like here, it was started here in my shoulder. The next time it came back, it was in my back. So everywhere is different when it comes back on me.
Thomas has fought multiple myeloma for at least a decade. After undergoing years of radiation, chemotherapy, and stem cell transplants using his own cells, doctors felt it was time to take a new approach. The answer was found close to home.
Yes. So being that I had a humongous family, I'm the baby of 11. All of my family was tested to see if they was a perfect match. Out of 10 siblings, I only had one perfect match, and that was my brother. So my brother became my donor for my next transplant.
The immune systems of some patients are not capable of keeping the bad cells from returning. These bad cells can often evade chemotherapy drugs, causing patients to relapse, even after undergoing high doses of chemotherapy and using their own good cells in an autologous stem cell transplant.
So the idea of using the stem cells of the donor, in Thomas' situation, his brother, was, well, can we use stem cells that they are not contaminated with myeloma? And can we use a new immunosystem and see if the new immunosystem, in this case was Thomas' brother, is capable of maintaining or controlling the disease from coming back. So it's a combination of chemotherapy, clean product, clean stem cells, and a new immunosystem.
Thomas was told that this approach of using a donor's cells, in spite of being a perfect match, came with serious risk.
The problem is the new immunosystem can attack Thomas, not only kill the myeloma, but also attack Thomas, and it's called graft versus host disease. So the risk of having complication and even dying during that type of transplant is very high. And we generally do not offer that approach to all patients with myeloma. We can't.
Thomas decided to go ahead with the transplant, and his brother Ernest dedicated his time to getting Thomas on the road to good health.
He'd get his physical done. And while he was sitting in the clinic waiting for it to get treated, just a checkup, other patients would come up here and ask him how long has he been sick, how long has he had cancer. And he'd look at him and say, hey, I'm not the patient, he is. So then they'll look up at me and say, well, you don't look sick at all. And I was like, well, he was like, yeah, I know, tell me about it. But I'm not the patient, you know, and he just started laughing because of that.
The outcome proved to be more than just trying to beat this cancer. It was a proof of love and dedication for the entire family.
It did bring me and Ernest together because we are considered one. Not only that, it brought my whole family together. It brought us all even closer for the simple fact that while going through transplant, they all took an integral part of coming and staying with me. So they all were my caregivers.
The celebration was short-lived, however, as the introduction of Ernest's cells into his brother's system presented side effects.
The first time I got his cells, yeah, I couldn't handle it. I started going into sweats, high fever, runny nose, and they put me in the hospital for the rest of it. So I did one treatment here, but the other 3 treatments, I did it in the inside of the hospital. So even after my 3rd transplant, I relapsed for the 4th time.
With the last relapse, Dr. Gasparetto prescribed a new maintenance medication along with an anticoagulant and steroid. The combination worked.
That got my cancer back down to normal, but what it did do is kill my donor percentage from my brother. So my brother Ernest had to come back again for a lymphocyte infusion. So I get lymphocytes from him instead of stem cells. So that boosts my count back up to 98% him. He's happy every time I say that, I'm 98% you.
So with the new therapies, with the transplant, in conjunction together or one or the other, we are able to give patients with myeloma a good quality of life.
Along a hallway at the Duke Clinic hangs an image of Thomas, taken during the time of his first bone marrow transplant in 2007. It's a reminder to him that every day is a gift. Like fellow myeloma patient Donna Kravitz, Thomas looks forward to living a positive life, regardless of his cancer.
You know, being myeloma is considered a non-curable cancer. Just don't let that be a decisive factor about you. Learn everything about the cancer, but then don't let it beat you. You beat it by living your life outside of myeloma.
Donna is also having success with proper medical maintenance.
So I get a small amount of a steroid and a shot twice a week. And that's it. The only problem is you have to go there to get it. I can't give it to myself. If I could, that would be great. Maybe I should negotiate for that. But right now I go just like it's any other errand, or running to the office.
And I think that a patient who comes to us today has every reason to be hopeful just because the state of the art today is a hopeful state of the art. That you could live for decades without an extraordinary change of the environment in which you're being treated. And then we are changing the environment. We are bringing new drugs all the time. So it's a very exciting time to be a physician taking care of the disease, and I think it's a very hopeful time to be a patient with the disease because the field is changing and the field has moved so far already.
Donna not only gives credit to her doctors, but subscribes to a sense of humor and the importance of projecting a positive persona to all those she encounters.
When you project positivity and you smile at people, you may not feel like smiling, but you know what? People love it. People love it when you remember their name. The nurses behind the counter at the lab when they check you in. You know what? It's makes me feel good, and you know what makes them feel good? It's a small thing you can do.
For more information about multiple myeloma, please visit these websites: the mmrf.org and cancer.org/cancer/multiple myeloma.